Ready?
Once you minimize that.
Okay. Right. Thank you very much. Good evening, ladies and gentlemen. I'm Ben Coleman. I'm the Deputy Leader of the Council, and I'm the Cabinet Member for Health and Social Care. And I have the pleasure of also being the Chair of the Health and Wellbeing Board, which is the one of the few places in the structure of local government National Health Service where we come together as one with the NHS and with the police, ideally, and with other services from the council. We have a wet day out there, which may mean that we have fewer people who are able to make it here than usual, but we have some people also joining us online. What I'm going to do is, rather than run through the names of everyone who's here, and we've got people here from the NHS, people here from Children's Services in the Council, Adult Social Care, from Health Watch, from the voluntary sector represented by SOBUS. I'm going to just ask people to introduce themselves as they come in, but I do just want to mention my colleague, Councillor Perez, who's here to my left, who's the chair of the Health and Social Care PAC. Welcome. Forgive me not mentioning everybody else. Dr. Lang, our extraordinarily brilliant Director of Public Health, has unfortunately given apologies for this evening's meeting. Can I ask if anybody has any declarations of interest other than a keen interest in what's going to be discussed? Okay, Alex, thank you. And we circulated before the meeting the minutes of the last meeting on the 28th of June 2023. We're happy to accept those as an accurate record. Yeah, great, excellent. Okay,
Councillor Coleman,
Yes.
Sorry, can I just come in? So that I think there is it's Sue on. I'm online.
Sue Rooston, hello. Sorry, I didn't see. Thank you.
Sorry, yeah, Sue Rooston from the ICB. I think there are just there's just one thing that I wanted to. It's a point of accuracy. I think we've still got Philippa Johnson down as in attendance on the June minutes, and she left in March, so she wasn't there at the June meeting. So I think that just needs correcting.
Okay. Yep,
Thank you.
We'll take that off. Thank you. Yes, we've got Sue Rooston. By the way, the people who are there, if you want to come in, don't feel shy about putting your camera on. And then we feel we're all in one happy mixed space. But Sue, it's nice to have you here. Okay, well, we're going to talk about, mainly we've got two main items to talk about tonight. We've got the Special Educational Needs and Disabilities Joint Strategic Needs Assessment and Strategy. And then we've got the Better Care Fund, which we'll explain a bit more when it comes to it. Then we'll look at what we'll cover in future meetings and the dates of future meetings. But we've got some great people here from the council and the NHS. As I say, we try to be an integrated body to take us through the Joint Strategic Needs Assessment. And we've got Peter Haylock here, who's the Operational Director for Education SEND at the council. And we've got Alison Markwell, who's the head of SEND Health Partnerships and the Senior Designated Clinical Officer. And I just ask you you're going to be doing the presentation together, is that right? And so if you could just explain what the JSNA is, the Joint Strategic Needs Assessment, and the strategy and the main points, and then we'll have a chat. Thank you. Over to you.
Sounds good. Thank you, Councillor Coleman. So I will start off, and just for kind of to make things clear. So the JSNA and the SEND strategy were developed across the kind of partnership of the SEND delivery group, which is a wide-ranging group involving school stakeholders, colleagues from health, colleagues from our SEN team, colleagues from social care, etc., etc. So myself and Alison are the chairs of that group, and it reports into the Children's Health and Social Care Board as well. So just for ease, the two documents will co-produce.
Just I'm going to stop you there, just because I know that we probably have not got the watching millions tonight. Okay. I think the 3 people watching, they pretty much know what's going on. But can you just be very clear what the JSNA is, what it does, and what its function is?
I was just going to come to that in a second. Sorry, Councillor Coleman. So what I was going to say was, just to make it simple, I will talk through the JSNA, and then I'll pass to Alison to talk through the SEND strategy. So the SEND, the SEND, Special Educational Needs and Disability Joint Special Needs Assessment, is one of our key strategic documents and draws together data and evidence from a range of different sources. It includes the views of parents and professionals working in the field to describe a picture of need and service provision across Hammersmith and Fulham. The findings of which have supported the development of a number of key different strategies, including the local area SEND strategy. So this goes beyond just the local authority, but focuses for our health colleagues as well within the local area, and the subsequent priorities within this document, and continues to inform other key documents such as the Special School Organisation and Capital Plan. We've tried to make the document as accessible as possible. The JSNA initially focuses on the local area context at a population level before concentrating on the education, health and social care analysis and the lived experiences of children and young people, which for me is the key element. The document has been well socialised prior to the board, including via the Health and Care Partnership, the Children's Education, Health and Social Care Partnership Board, and it is brought to the Health and Wellbeing Board this evening to note alongside the SEND strategy. I'll now pass over to Alison.
Thank you very much, Peter. And as Councillor Coleman said, I'm Alison Markwell. I'm the head of SEND Health Partnerships and Senior Designated Clinical Officer, and nice unique position of being jointly funded by both the local authority and the NHS, so hence my two name badges. And I think that really reflects our partnership approach to SEND in the local area. So the SEND strategy, as Peter has said, sits alongside a number of key strategic documents, including the SEND JSNA, our early intervention strategy, our joint commissioning plan for children and young people, which we're just finalising, and other documents that I think will probably make their way here in due course, including our local self-evaluation. And these documents together outline our approach to delivering our responsibilities around SEND and the responsibilities across partner agencies across the local area. This has been in development for some time as a strategy, and has now got to the stage where we're very happy to bring it to you this evening for noting. There's been extensive engagement with families and our partner organisations. I'm sure many of you will know Parents Active as one of our key stakeholders, but it's also based on what we've called hundreds of everyday conversations. So actually every day, all of our staff, whether that's in health providers, the ICB, the council across children's and adult services, are interacting with our families, with schools and things. And it's that richness of that voice, as well as through formal consultation, that has really helped to shape the strategy. It outlines our vision and the principles that we're committed to in terms of how we work together. And involves our health, as we've said, education, voluntary and community sector. It's been through governance in both the Integrated Care Board, so it's been to the Health and Care Partnership, and in the local authority, including Cabinet. You'll see it articulates our three key priority areas, which are early intervention, assessment and intervention, how we ensure that we've got sufficient, inclusive and effective local provision, and successful preparation for adulthood, so that transition across health, education and social care, so that we can achieve the best possible outcomes for our children and young people.
Thank you very much, both of you. I'm going to ask people to ask more questions, but before they do that, I'm going to just ask a couple myself. I just wanted you to set the scene a bit more, if you would. Peter, looking at the SEND, looking at the Joint Strategic Needs Assessment, which informs the strategy, because you know what's out there and what the situation is, and then what are the big things that jump out of you if you were going to describe the situation for children and families with disabilities, children and young people with disabilities and their families in the borough? What does the world look like at the moment that came out of the Joint Strategic Needs Assessments, in a nutshell, if you can?
So I think purely and simply, what we're seeing is that the number, or say the percentage of children and young people with complex needs is increasing significantly. And that is kind of happening in very much in the early years sector at the moment, and the challenge that therefore that sector faces in terms of meeting that need is extensive. So, for example, the amount of money that we provide through what's called the CENIF, which is the inclusion fund for early years, is becoming a real challenge, because the funding is reducing, but the need is increasing, because although our numbers of young people are reducing in terms of the birth rate, that's not necessarily kind of playing out in terms of the level of need, which is actually going in the other direction.
Why is the level of need?
I think it's a combination of different factors. Without kind of wishing to hypothesize too much, I think that the number of young people in terms of live births improves due to the medical care, etc. So that's one of the key things. I think our diagnosis is better. I'm actually going to transfer to Alison because I think she's better versed in this than me. But I think they're the kind of two key things really.
I was going to say, I think effective early identification, that where perhaps sometimes previously children wouldn't have been identified as having special educational needs and disability. I think that understanding of what we mean by SEND. So this isn't just about children with education, health and care plans, and the 4 domains that we talk about in terms of SEND are cognition and learning, communication and interaction, sensory and physical, and social, emotional, mental health. And certainly we've seen that growth in the number of children and young people with social, emotional, mental health needs. That was growing anyway, and then obviously lockdown had a significant impact.
Are we saying when we're talking about mental health needs, we're talking about older children or young or very, are we talking from birth?
Not from birth. I think it's quite difficult to identify a very, very young child, but we are seeing early on, and that might be from trauma, family circumstances. We all know the impact of the cost of living, crisis that we're seeing, children living and growing up and only having grown up in poverty. And I think that has an impact. And I think it's quite difficult sometimes to identify, is that presenting as a social and emotional need versus what we might formally within health call a mental health need?
Are you, just to clarify that, are you saying that some children will be born who won't have a mental health need, and as a result of living in poverty, they will develop one?
I think we will see children that, the determinants of health are very, we can be fantastic in terms of our services at Chelsea and Westminster and Charing Cross and things, but actually the socioeconomic background that you're born into, your ethnicity and your gender have a significant impact on the wider determinants of your health and your life outcomes. I'm not a public health expert. So.
When you talk about ethnicity and gender, is the point that you're making, and I'm not trying to put words in your mouth, so if that sounds, if I am, correct me, is that people from certain ethnic backgrounds are more likely to be poor, and that would have an impact on disability, or what's the point that you're making?
So, people with certain ethnic backgrounds are predisposed to different health conditions. So we see, a classic example would be sickle cell. But aside from that, in terms of certain cancers, heart disease, very much is linked to ethnicity. So you've got that alongside the circumstances in which families are living and the challenges that they're facing every day.
Somebody actually, I had my surgery yesterday, and somebody young mother came to see me who is at the moment in temporary accommodation in a hostel, where the council's had to house her because we have such a shortage because we haven't got the money to build enough flats. So we've been trying homes, which we're trying to do that. And her son has autism. I have to say she's one of the, he has a diagnosis, which is already something that doesn't happen for many children with autism. But his behavior, she says, is definitely being exacerbated. His difficult behavior is being exacerbated by the extremely unstable conditions that they're living in, cramped and unstable. So I hear what you're saying. Before we go on to the strategy, I'd like to take a bit more from you, everyone here, if you wouldn't mind, just to analyse a little bit more, understand the analysis that the JSNA has done a little bit more and about the issues in the borough. I don't know if anyone would like to ask. Sue, you'd like to? And then we'll go to the strategy, which is what we're going to be doing to address this. Thank you.
Yeah, I'm just really interested in the profile of SEN young people in the borough. How confident are you that we're reaching all of the children who might have SEN needs? And I'm also interested in the co-production angle, because there are so many voluntary and community organisations out there that are working with those really isolated communities. And, were they involved at all in the co-production process? I mean, it's great that you've involved some, but they're not always reaching those really excluded communities. So I do wonder how confident we feel that we're reaching all of the young people that we need to.
So in terms of the JSNA specifically, I think the second question we might be best coming back to when we talk about the strategy. So in terms of the JSNA, it's based on very much on the population data. We look at all of their early health notifications, etc., and it gives us that opportunity to kind of extrapolate out in terms of where we're looking in terms of the population and the trends, etc. So I think it's a fairly good representation of where we stand in terms of our knowledge of the community and what's happening, and it's built on quite robust data sort of historically and how that kind of moved forwards. We've got pretty good systems in place for kind of for the monitoring of that and looking at kind of the early identification of need, for example. So a lot of that comes, for example, through the Stephen Wiltshire Centre and kind of some of the different panels that we have available to support the parents, etc. And similarly, the work that's done through the hospitals that Alison mentioned previously.
But is it dependent on parents coming forward to ask for that support, or is it picked up somewhere else in the system? Because where you have parents who might not understand the processes and the systems, or might not know that there's any support to ask for, or might not understand that there's an issue here, how do you find those young people?
Do you want me to add? I think through a variety of methods. I think there is always more to be done in terms of the co-production. I wouldn't want to sort of sit here and give you the impression that we think we've sussed sort of it. Parents Active are our formal co-production strategic voice of parents, and actually both the ICB and the local authority have just invested some additional funding into Parents Active, but with a particular brief around them evidencing that they're extending their reach and reporting on that to us, which hasn't been the arrangement so far. So I think that's a positive. We've had a recent project that was funded, a grant we had from NHS England, working with children and young people who are on our autism diagnostic list. So you might note from the papers that that's a lengthy list, which is not acceptable, but it's not out of kilter with regionally and nationally. And we had an additional integrated key worker working with educational psychology around how we directly offer support to those families who are identified whilst on the waiting list as those who might not reach out. So whilst we've got a waiting well offer and are strengthening that waiting well offer, we absolutely don't want it to be a question of the help is there, but you've got to come and ask for it. So there is that, how do we go out and look? So we've been working with ASHE as well. I think our education settings and at preschool as well as formal school age are a really rich source of information. So some of the work is what we do directly, and some of that is how we socialise what we call our local offer, so that people who are out there, whether that's our health visitors, whether that's childminders, whether that's our staff in schools, also know of the support that's available. So I can't sit here and say we're reaching absolutely everybody. I think we're reaching more than we used to. And we are absolutely determined to make sure that we continue to strengthen that co-production and don't rely purely on Parents Active. We've got, say, West London Trust, I know Helen is here, have a couple of user groups in terms of children and young people themselves with lived experience of mental health and parents. And those typically don't overlap with the membership of Parents Active. And that's been a really rich source of information for us. The ICB have commissioned an organisation called Rethink, and we've got some young mental health champions to do some of that co-production for us, and that's been very rich. And we've had insight into young people with lived experience of having had inpatient admissions as a result of their mental health. Thankfully, a very small number, but if you get to that point, that's a very difficult situation for families and young people themselves.
Thank you. Thank you for explaining that. Now I'm going to take some other questions now, because I think people would like to come explore some of that. Leslie.
Thank you very much.
Natalia.
Thank you very much. Yes, I'll start again. Sorry, I had the microphone off. So the report references some concerns in relation to waiting times due to waiting time for diagnosis, due to workforce shortages. So what are those concerns? What impacts does it have on families or children waiting? And what provisions are there? And what are we doing to address some of those concerns? Thank you.
So I think our particularly long waiting list is for children who are on the social communication diagnostic pathway, so who may or may not end up with a diagnosis of autism. The ICB have invested over I want to say it's 1.2, 1.4 million into improving the weights. Part of that is outsourcing to a third party, but who are offering very, very credible and are doing face-to-face assessments of children and young people where it's felt that's a very reasonable offer to make. Alongside that, a Cheney Child Development Service are recruiting, so they have an additional clinical psychologist starting, an additional paediatrician. There are challenges in the market in terms of recruitment, but we are also recognise that whilst you might not get a diagnosis, you may end up with a diagnosis of autism. That doesn't then lead to a prescription of antibiotics. So actually the diagnosis helps clarify things, but actually the needs are still the same. So how do we meet those needs while you're on the waiting list? So we have what we call a waiting well offer, and are very much looking at strengthening that both across children and young adults, because we have waits for adult diagnosis of autism.
Forgive me, on autism, the wait is ridiculously long,
It
and we've known about that for years. And I'm looking here in the strategy, and I know I'm jumping between one and the other, and there's nothing on that really sorting out the wait for autism. And it's been a massive problem, which we recognised years ago when we started as a council to try to address this. And it does matter if someone has a diagnosis. For example, when it comes to housing, if somebody is trying to get improved housing for their children, one of the arguments that they can make is they have a diagnosis of autism rather than the parent just thinks their kid may be autistic. So I don't see much in here unless I've missed, and I'm very happy to have misunderstood it, on improving the diagnosis of autism. Wouldn't that just require you really just to hire somebody else to do it? There's not enough people doing it?
And that's what the additional investment is. And there has been an exponential growth in referrals as well. But Cheney, who've had the money and had money previously and really struggled to recruit. So part of our challenge and across speech and language therapy, occupational therapy and paediatricians is the workforce that's out sort of there.
Are you doing special things to try? I mean, this has been a problem for years. Yes. So are we offering a bit, are we doing things like offering a bit more money than other people would, or extra incentives, or?
I don't know the details of Cheney's recruitment package, but there has been successful appointments recently, and our number of children waiting has come down. So 400 assessments have been purchased privately. In terms of things like some of our therapy services, so we've had a particular challenge in the local authority around occupational therapy. We got agreement to recruit overseas and to pay the cost of healthcare professional council registration and to do visa sponsorship.
Right, so good. Are you saying then the 400 people that you've paid for privately to have assessments, these are people with autism? And what is the waiting list at the moment for assessments?
So the waiting list for assessment, it's the numbers waiting at the moment. Can I come back to you on that information? I don't have it at the top of my head. Okay. It's in our self-evaluation, and there is a recovery plan in place in relation to this that sits as part of our self-evaluation.
Jackie would like to come in.
Yeah, I was wondering, Councillor, what we had hoped to do was to bring our self-evaluation and our action plans that sit beneath the strategy. So the strategy provides the highlights and the overarching. It's not an action plan, and we do have action plans and recovery plans underneath it. And I was going to suggest at the end of the item, but just to bring it in now.
That would be helpful. I just noticed in the study itself, in the strategy itself, it's thin on autism, and I mean I may have missed that, so I'm sorry. And I'm really worried about not just here, but generally the fact that we haven't been able to. There's been one woman run ragged for how many years now? 4 or 5 years, trying to do all the diagnosis for more than one borough. and we had a discussion at the Integrated Care Partnership for the 8 boroughs of Northwest London, and they're coming up with a strategy for Northwest London, and it was thin on autism. And it said we're going to look at autism, but there was nothing in the strategy about doing it. I think autism, and I'm looking forward very much, Jackie, and I very much welcome your offer and take it up to see the detail of how we're going to address that. But for this borough, autism has to be taken very, very everywhere, I'd like to think, but this borough has to be taken very seriously, and assessment, diagnosis, we very much would like, I think, as a board, to see that strengthened. Did you want to come back before I bring Linda in?
Just a follow-up in relation to this topic. So I'm just thinking about the impact that it has on families or children waiting, that and the anxiety that might generate and maybe exacerbate challenges that they're already facing. So is there a system in place for families who are on the waiting list, who may have presenting situations or emergencies, where they can be assessed faster and quicker?
So there's a triage system in place of those who are felt to need assessment sooner rather than sort of later. Cheney are also now doing a check-in for regular points of people on the waiting list. For children under 5, there's a statutory responsibility on health to notify the local authority of any child or who they think may have special educational needs, and you don't need to have a diagnosis for that. So those referrals come through to the Stephen Wiltshire Centre. The Stephen Wiltshire Centre then reach out to families. We have a stay and play group, and we have one at the Stephen Wiltshire Centre. We have one in the north of the borough at Old Oak, where we have our jointly funded integrated key workers. We've run a programme of while you wait groups jointly with educational psychology. So looking at what the support is locally that's out there, access to benefits, understanding your child's behaviour and seeing it through a potential lens of an additional need rather than just a naughty child, language and communication skills, accessing education. So there's a whole range of support out there. And obviously once a child or young person hits school age, then there is support through our what we call our ordinary available offer that very clearly lays out what schools are expected to do, and either within their own resources or being able to call on the expertise of some of our services like Inspire, which is our specialist outreach things. And you don't need a diagnosis to access speech and language therapy, occupational therapy, and services like
Thank you.
that.
Thank you. Linda.
Yeah,
so I can just ask you to introduce yourselves.
Thank you. Yeah, Linda Jackson, Strategic Director of Independent Living and the DAS, and also Leave Public Health. Just a couple of comments, and I'm going to work backwards if I may. In terms of autism, we as a council and the NHS have just appointed an autism lead to develop an all-age autism strategy. So we know the offer isn't good enough. We know it's not joined up. So there is work in hand to do that. And I really don't want to, although it's really important, detract from the SEND wider piece of work there is here. I think our challenge is not just about diagnosis, it's about making services accessible to people with autism, including the housing waiting list and medical assessments, etc., of which we have many examples. I think in terms of co-production, I think you're right. So reaching those that are furthest away from decision making is a challenge for the whole of the council and the whole of the NHS, which is why, and Sue's on the internet, that we've made it a priority for the Health and Social Care Partnership in Hammersmith and Fulham to do co-production. And I think, you know, it's really important we do that, but we do that jointly and we have an approach to doing it. So people are not getting tired and sick of being asked too many times, and it's meaningful. And just, I think the final thing was really just because we're talking about the JSNA, we're moving on to the strategy, just to commend the JSNA chair, because it's an excellent piece of detailed work, which is clearly generating a lot of questions, which is what any good JSNA does. So I just think, and we've got a lot to actually take from this when we look at other areas. Thank you.
No, that's a very good point. I could just bring Nadia in. It is good for us to have a JSNA which tells it warts and all, because then we can, we're not here to do anything other than identify the problems and how we're going to challenge and address them. And there are some issues, some things the JSNA throws up. So that is a good thing. Nadia, and then we're going to move on to, after this, Nadia, I just want to say we're going to move on to asking Alison just to give us the outline of the strategy, and then we can ask any question about anything. So we're moving over into the strategy discussion anyway. But Nadia.
Thank you very much, Chair. So
just introduce where you're from.
Nadia Taylor, representing Health Watch this evening, but I may well be bringing the carers perspective as well. I chair Carers Network. So obviously from Health Watch's perspective, we commend and acknowledge the plans, firstly, to produce a local area PFA pathways document and toolkit for professionals, families, young people, to ensure that routes are clear and defined across education, health and care. And also to develop a local area protocol and approach for managing transitions with the care plan at the core of provision and pathway planning. But we do know that pathways, transition and support available have been a source of confusion for residents, because we have, as you know, the Health Watch information and signposting program, wherein residents contact us via phone, email, or in person, looking for guidance about services. So we also aware anecdotally through doing engagement with local residents, particularly across the north of the borough, that families with young children with autism, ADHD, or other nonverbal conditions, many of whom are saying that this part of the borough is actually lacking in sufficient autism SEND support, and that south of the borough, particularly in Fulham, there's more support available, but they're finding it difficult to travel to. And of course, the cost of living plays a part here as well. So just it's an interesting comparison between what's available within the borough.
Are you asking why? Because I mean, let's make a question out of it.
I'm just about to pose the question. Sorry, Chair. So I would like to query if we're actually assessing ways to share provisions across the borough, or looking at the impact and time travel costs on both the local resident and the service. And then I have another point about young people and mental health, but I will give you a chance to respond to that one first. Thank you.
I think the answer is yes. We are absolutely trying to it not be everyone has to come to Chelsea and Westminster Hospital or the Stephen Wiltshire Centre. So I'm not sure how cited the Health and Wellbeing Board is on the Family Hub development. So that's another new initiative. We're going to have 3 family hubs. Stephen Wiltshire will be our specialist hub, but with that hub and spoke outreach model, so reaching into our other 2, one of which is very much in the sort of north of the borough, but our reach into our children's centres as well. So this isn't all about people coming to the specialists, it's about how the services move. So I know Helen from West London Trust, and we've got a really interesting project about early identification of under 5s in terms of very early mental health, and that's not being delivered at Glenthorne Road, that's being delivered in our children's centres. So where possible, it is absolutely about taking services to the children and young people in settings and in schools. We get a much more natural view of a child rather than them coming into an unfamiliar sort of building.
But Alison, just to clarify, sorry, forgive me, because this is it's very professional what you're saying. It sounds very good, and it's just sometimes it's easier to just clarify it. If we've got more kids with autism in the north of the borough than in the south, but we've got more provision for people with autism, children with autism in the south than the north, it sounds a bit skewed. Are you saying, how will the hubs change that, the provision for people? How will, if parents have children with autism, how will the hubs make any difference to where they have to go for, where they're able to go for support?
Do you mean in terms of schooling or in terms of other support? That was the question I was going to ask.
Do you want to press your quick mic on?
I think the chair sort of dissected the question very aptly. So thank you for helping me out here. There clearly is a sort of a discrepancy between what's available in terms of services generally in the north and south of the borough. And it seems that families who need support from the north are having to travel long distance.
As just to pick
So
Peter up,
are we,
what sort of support are you talking about?
ways? How can we improve access really is what I'm trying to say. And
What sort of support are you talking about, just to help Peter?
well, support with diagnosis, any services that are available for families with children who have autism, ADHD, and other sort of non-verbal conditions, because it does seem to be this imbalance of what's available north and south of the borough.
So I think the first thing to say is we're very lucky to have the Stephen Wiltshire Centre at all in terms of what it provides. And the intention with the family hubs is to be able to take those services that exist there and to operate them from different centres at different times. Obviously, you can't run everything at the same time in the same place. So the whole purpose of the family hub is that you have a specific service that's available, let's say on a Monday afternoon in one place and then on a Tuesday morning in another, and being able to spread that in terms of equity across the borough is really key. In terms of schooling, obviously we have Queen's Mill School, which is a absolutely brilliant provision in terms of what it does for the young people. They run a number of different what's called satellite provisions at the moment. What we're looking to do as part of the SEND sufficiency implementation plan is to look at expanding that provision even further, looking at the development of resource bases, looking at how we can operate some of those in our primary schools, some of those in our secondary schools, to be able to meet more of the need for autism and other kind of special educational needs locally. One of the key drivers for that is to reduce travel distances for parents and families, and as a part of that plan over the next 3 to 5 years in terms of implementation, we will be looking to make sure that we've got equity in terms of location and trying to match that as much as possible in terms of the need. You'll notice in the JSNA, when you look at the location of young people with EHCPs, is obviously a significant number in the far north of the borough and also in the far south. So looking at how we kind of try and match that to our provision is quite key in terms of what we offer and what we provide.
I mean, that's exactly the
Thank you,
sort
that's
of,
very
thank you,
encouraging.
Nadia, and that's really helpful. And that's exactly the sort of conversation that we're able to have because of the JSNA and because we have people here who know what's going on in the borough. So thank you very much. So let's talk a bit about this. There's a sort of, we're obviously, you can't just talk about one and not talk about the other. Alison, would you give us a bit more of a deep dive into the strategy to say the big things that are coming out of it? Really what you're doing that's different and which will get better outcomes for people would be really interesting. If that's what you'd like to do.
I suppose picking up Jackie's point is that that's the action plans that lie beneath the strategy, which we're hoping to be able to bring to you separately, so our much more detailed self-evaluation. So we've got, we've, I think, talked about the initiatives around our social communication diagnostics waiting list at the moment, and support in general for children and young people on that pathway. I know you have a particular interest in preparation for adulthood, so I'll preempt your questions and perhaps tell you some of that. It's an area we recognise.
So Alison, just before you come in, if we just reiterate that this is probably the first time that we've got such an well-articulated strategy. So there's been work and train, but it hasn't quite been brocaded under any particular sort of banner of what we're trying to achieve. So for the first time, we are holding ourselves to account in a very clear way so that actually these questions and discussions can happen. Not everything will be resolved immediately, but that we can come back again and again and to be held to account, as opposed to something that looks, is happening, but is a bit amorphous and hard to be clear.
To be honest, I think, thank you, Jackie, as Director of Children's Services, Strategic Director of Children's Services. I'm saying for anyone who doesn't know, actually, it's good that you come in and made that point, because the needs that disabled children and young people and their families have are so great. And we haven't had a strategy like this before. We've done good work and a variety of different work, but we haven't had a strategy like this before. And I guess I've worked in this area for a long time before I was councillor, I helped set up something called Every Disabled Child Matters and work with a lot of charities in this field, life limiting conditions and all sorts of other things. So I'm really, really, really pleased that you've got this strategy. I'm really excited by it. And I suppose it's my enthusiasm and other people's enthusiasm that this strategy is unlocking, that we all want to, that's why we're asking challenging questions. But the fact that we have a strategy that we can discuss, which gives us the opportunity to ask these questions and probe, is in itself something that's very welcome. So thank you for making that point. Back to Alison.
And Councillor, we welcome all the questions, because that actually, I mean, all these questions are, you know, allow us to keep reiterating what the work we're doing and double checking. So, you know, the email tomorrow will be, you know, how are we actioning some of the questions that happened today?
Thank you. That's great. So Alison, back to you then to talk about a bit more about the strategy.
Sue's got her hand up.
Sue, I'm sorry. Do you want to come in?
You wanted to go? No, Sue Rooston.
Rooston, Sue, hello, welcome.
Hi.
Do you want to introduce yourself and then say a bit?
Hi, I'm Sue Rooston. I'm the Borough Director, but I'm also the Health and Care Partnership Director for Hammersmith and Fulham. So work closely with Linda and our executive colleagues. I know Helen's in the room as well. And I also jointly chair with Jackie the Children's Board. So actually, I think it is a really exciting thing to be bringing, that actually it's a strategic document that is quite succinct and clear, and I'm sure Alison will go through it, but I think it's a real good opportunity, and I know it's already been said, but I think, you know, the strategic bit is the what, isn't it? And actually we've got the other bits, that the action plans and the other bits that then will determine the how, and it's not going to happen overnight. I think we all have to recognise that, but I think we are getting in a better place as we go through. So I just want to thank Alison and Jackie and Peter for all the hard work, and Joe and everybody in the team, because actually it is it's the first time that we've been able to do something like this in this sort of fora. So I think yeah, we should compliment that.
Thank you, Sue. And Sue, I should make it clear that you're the head of the local NHS in the sense you pull it all together. Is that right? For those who didn't know. Thank you. Good point. Alison.
So back to our headlines. So I think we've got the three priority areas. It's easy to say there's a huge amount of detail that sits below sort of that, and those are borne out in our plans and our work streams that sit under the SEND delivery group, which Peter and I jointly chair. So that first priority is that early identification and effective assessment and early intervention, because we can do things, but we can all do things that don't make a difference. We're keenly following the national SEND review and the commitment to look at the programme of evidence-based work. So there's sort of starting around speech and language sort of development and that. We've been overly reliant on speech and language therapists. For those of you who followed the SEND agenda for a long time, the Burko report that is about 13, 14 years old now, that very clearly said speech, language and communication needs are everyone's business. And I think we've had a holy grail of this all needs to be about speech and language therapy, and we know it doesn't. So we've got a really great initiative that's referred to here now, joint communication team. So working with schools to do a screening tool, to have that identification of who are the young people in class who've got some degree of language and communication needs. Of those, what needs an intervention but can be met within the school, what needs support from the joint communication team, and that's a team made up of specialist teachers and speech and language therapists seconded from CLCH, and who needs the intervention from a speech and language sort of therapist. So that proportionate and graduated response to sort of need, and that approach is really mirrored across quite a lot of sort of areas. We've our social emotional mental health needs, again, that graduated approach. So we have mental health support teams in schools, overseen by Mind is our key partner organisation who employs those, giving us that graduated support, an online digital offer for children and young people run by Cooth, who is a voluntary sector, and then that our educational psychologists provide some of that graduated support. So all that's available before you need to hit the front door of CAMS. And then we have our community CAMS and our specialist CAMS. So that proportionate early identification and then a range of services to meet need. We're very keen to make sure that we measure how to make a difference. For those of you who were here in 2018, when we had our SEND inspection under the original framework, one of the questions posed to us by inspectors were, you're clearly doing a lot. How do you know you're making a difference? We weren't the only local authority and local area to have that challenge. So one of our other suite of documents is an outcomes framework that we've got, and that's been very shaped by children and young people. We've got our SEND scorecard, which is about to go to our Health, Education and Social Care board. But our outcomes framework has been shaped by what matters to children. So what does being healthy mean to you? What does being safe? What does being included in your community sort of mean? So we are really holding ourselves and each other to account within the partnership, and clearly forums like this are holding us to account on a sort of wider basis. So I think that governance has really been strengthened over sort of recent years. Very much working in schools. Peter's referenced our SEN sufficiency piece of work, where we did a lot of detailed work in what the trends were, in the key reasons for asking for an education, health and care needs assessment, and us issuing a plan and SEN support level. Where were our pressures in the system in special school places? Where were we needing to place children out of borough or in the independent sort of sector? And we've got a great strategy around looking at having more of those resource bases across the borough so that we can meet needs more locally. That then means children are alongside their peer group, not all having to go to Queensmill or somewhere, and you know, more part of their local immediate community. So there's a whole range of things around that early identification, meeting needs, having inclusive provision. I don't know, with Pete, whether you want to say anything about schools and the graduated ordinarily available, because that's one of our big priority areas, isn't it?
Yeah, so schools are provided. Sorry, schools are provided for notional funding for special educational needs, and it's one of our jobs to hold them accountable for how they use that. So what we are always looking to do is to try to meet need before the need to apply for an education healthcare plan. So the ordinarily available identifies for schools and for SENCOs within the schools the types of provision that can be put in place, and then we'll support them with an application when a child or young person requires that kind of plan and that additional funding to support them. So schools have been very much involved in the co-production of that kind of document, and that has also come through to Cabinet just very recently.
May I just add there, Peter, that we track Ofsted inspections of our schools, and there's consistently a strong reference to attention to special educational needs, disabilities, and how children's needs are met. And in the JSNA, just flicking back to it, you'll see that the outcomes are in line or exceed expectations at most key stages. We've also introduced a new role, an area-based special education need coordinator, and that's an innovative role that will go around and work with schools to ensure that they are continuing to evolve their offer to children and young people and their families.
Good.
And that is very new. This is the first term of operation.
Well, that's very encouraging, because I was just about to ask you something. I should have mentioned I was a governor of Jack Tizard School for 8 years, and then I was a governor of Queensmill School for 6 years. And when we were, particularly when I was with Jack Tizard, one of the things that we discussed a lot as governors, this is before I was a councillor, was the need for us to go out to schools and help schools work with children, pupils, students who had special education needs, were disabled in some way. And we funded that. We always had the challenge of funding it ourselves. And we had an exceptional person at one point, I remember, who went around and even sometimes just gave little equipment to people and made a difference. And are you saying now that we're funding somebody like that who also goes around and actually helps teachers in mainstream schools, gives them, sometimes it comes down to tips, I could put a more sophisticated word. Is that what this person's also doing? And do they work with Jack Tizard and Queensmill as well on what they think would be helpful in mainstream?
I think we've got a range of people who do that, and the area Senko is a great recent addition. So one of the things we are doing, Councillor Common, is to mobilise the expertise of our special schools in supporting our mainstream schools. So Peter, Daryl Mathurin, Joe Gunning and I did a series of going around all our special schools towards the end of the summer term, and really having that conversation around what's the outreach model from all of those sort of schools. Because we want to share that learning and expertise, and you'll know the staff at Jack Tizard and Queensmill who are very keen to share that expertise.
They have the funding to, do they now have the funding with the challenge? I don't know what their budgets are, and I don't know what the money they have in the reserves and so on, but do they have the funding these days to employ somebody to do that outreach? Or is it something which, if it would be generally helpful to all schools, the council will fund, in particular in Jack Tizard or Queensmill?
So funding is very much a challenge, and increasingly so. So what we have done, for example, in terms of autism, that's where we have the Inspire team. So we have a team internally within the council that goes out to support the children and young people with autism, and the schools to support them, and the Senkos and the teachers, etc. So that program is developed, that's funded by us as part of the high needs block, and it's something that we deliver similarly with the JCT, the joint communication team, and working with young people with speech and language. We're looking at an additional element in terms of Jack Tizard and how we can potentially work with them, but we would need to try and find that kind of funding ourselves from the high needs block or elsewhere, which obviously does create a challenge.
It seems to be, it would make a huge difference, but I just know, again, from obviously I'm a bit out of touch with projectors. I haven't been a governor there for a number of years now, but it really did make a difference at the time. And it was like, for some people working in mainstream schools who felt they were in a desert, it was like a drink to them. Having somebody just come in and give them simple tips and ways of doing it is probably seems cost effective. I know we all know we've lost over the last 13 years, the council has lost the equivalent of £50 million of funding, and nobody thinks that £50 million just doesn't, you know, what's £50 million between friends? We know that £50 million and the way that your budget's been decimated over the years and hacked back, and disabled children have not had the support they need in the last 13 years. We know what a challenge it presents, and I'm really therefore so pleased to hear the clever ways you're trying to get around it. But sometimes, you know, that said, it will save money in the long term, won't it? The better that children with disabilities are supported in mainstream school through perhaps the support that they can get through outreach from disabled specialist schools, that will save money in terms of their behaviours and their outcomes in the long term. So I do hope you can find money.
No, absolutely.
In that area.
Yeah. So one example, for example, is we commissioned the Ormiston Academy Trust. So I'm trying to not use all of the acronyms, to support with the SEMH provision, and they go out into the primary schools and secondary schools. Social and emotional health, mental health. Apologies. So yeah, that's a kind of key part of what we're trying to do. And Jack Tizard and potentially using that would be another kind of string to that bow in terms of developing that provision.
I'm going to ask if anyone else wants to come in. I know you want to say a little bit about what I call transition, what I think you call preparing for adulthood, but Helen.
Thank you very much. And I'm sorry to have a sort of tidal wave of questions, which is a bit pent up. So, but this is very much to everyone who's here. Sue, I know you're on the call as well as Alison. So I'll go through one by one. I just wanted to start by, this is much earlier in the conversation, saying I think it's quite uncontroversial to say that children living in deprivation are overrepresented in SEND needs. So I would hope that would form the approach, but it's not. I hope there isn't squeamishness about that. That's just evidence. Yeah. In fact, it says in your presentation that 68% of pupils with an EHC plan live in the top third most deprived places in the borough. So that's just fact. Yeah. Okay. So I wanted to, this is more a point that I might sort of, I possibly should already know, but if there are the discrepancy between the pupils receiving SEND support and those who have an EHC plan, what's the difference in that number? Why does sort of everyone not have an EHC plan?
So it depends on level of need. So,
Okay, oh, I see.
so that's,
Okay.
so the SEND support would be those people that are having their needs met by the ordinarily available.
Yeah.
So that document that we were talking about before. So we actually have a slightly higher percentage than national in terms of education healthcare plans, and a slightly lower percentage in terms of national in terms of SEN support. And that's partly due to good identification, and then
Yeah.
also partly by us needing to make sure that we develop the strategies that we've just been talking about to be able to meet need earlier and better without the need to apply for a plan.
I see. So it's a higher threat, higher kind
Yeah.
of threshold. Understood. And the 5% of pupils with the EHC plan as opposed to kind of 4% nationally, is there commensurate funding that's given? Why do I suspect I know the answer to this?
Do you want the short answer? So the number of plans is
yes, I've got
increasing
another 8
and the
questions.
funding is decreasing.
Right.
Okay. Across the country, I can imagine the number of children who require support is increasing and the funding is decreasing.
Yeah, so the nationally it's increasing at 9%. And our increase was around 6.5. It was higher than that previously. And the funding is very much remained flat.
Okay. So at the end, I'll ask the questions so people can get start getting their answers teed up about. There's no mention of ICS or ICB pledges in the presentation, or I think the strategy, but definitely the presentation. I wonder why that is, because I believe that it's meant to be a third of funding given to children and young people. So I wanted particularly health professionals perhaps to nod to that. So I'll give you a minute to simmer on that, but I wanted to go back and ask, in terms of diagnosis, between GPs, schools, parents, social services and diagnostic technology, I wondered what the gap is here, and it might be staffing, or there might be a number of very sort of wicked issues here, but what the gap is in an ambition to diagnose every SEND child.
So if I start with your last question first, you can have SEND without having a diagnosis. So you a health diagnosis doesn't necessarily constitute SEND, and one of the key drivers of the Children and Families Act, which came in 2014, was that we should be looking at need and not diagnosis, and that diagnosis shouldn't determine support, so that each child should be seen as an individual. So you could, for example, have a child with diabetes. Now, most children who are diabetic wouldn't be considered as disabled, but some children with very severe diabetes, unstable diabetes, very young, may reach the threshold of being considered to be disabled. Now, that's not something that probably ordinarily you would think of, you know, diabetes and disability in a child, but that's only a very few children, and you could have autism as a diagnosis, but actually function very well and achieve very well with very minimal support in a school that understands your need, whereas someone with a more severe level of autism may need the support of an education, health and care plan. So we're very much encouraged not to be linking diagnosis with SEND and with provision, to look at each child as an individual and what their particular needs is and the support around it.
If I may, just so never want to sort of overly medicalize, but if we're just saying identifying what people need to live their lives well, and that might be a diagnosis, or you're giving some split in terminology, I would be cautious about, this is not my expert area, I'd be cautious about not registering people's needs in some way and implying there's medicalized or non-medicalized terminology, because otherwise how are you ever going to define the extent of the need, the extent of the commensurate workforce that you would need to support children? We've mentioned about autism so far, etc.
I think because the challenge is that just because you have a medical condition, or that doesn't necessarily translate into a particular level of support. And we have lots of young people who receive support at both SEN support level who don't have a diagnosis. And that might be that they present with some level of social, emotional, mental health needs, but don't formally have a clinical diagnosis of anxiety or depression or OCD, but the way they are presenting in the education setting means that they have been identified as requiring additional support. So I'm not saying that diagnosis isn't important, but I think there is a danger of an over-reliance on diagnosis, particularly for some areas of SEN.
So are you anchoring diagnosis as, is it an NHS bottleneck? Is that I just don't really understand the schism in this word diagnosis versus just identifying the needs of children or young people, for
I wonder,
instance.
Councillor, if we think about what are the barriers to children achieving their potential, and those could be educational, social, as well as health. So we're trying to think holistically, not just in terms of one aspect, which is an important one, which is medical, but actually, we're asked to think across the piece about all the different ways we can help all children realize their full potential.
If I'm going to just come on this, if there's a diagnosis, you're more likely to get an educational health and care plan. And that's, I'm just asking, is that the case? No? Okay. And that doesn't necessarily unlock funding, and therefore it's not okay.
No, not at all.
And what
I'm
sorry, Councillor, what we're trying to do is try and meet that point, the point that I said. We're trying to identify those additional needs, potential barriers, and provide them earlier, so that actually, hopefully, they're resolved where they can be earlier, and avoid them escalating.
Good. I've got to apologise for something which isn't my fault now. That clock's 5 minutes slow. And I've been going by that clock, and I know that you have to go and do Ofsted type things. So I'm not going to ask you to talk a lot about transition tonight, or which I notice is the new phrase that's preparation for adults, but it's replaced transition. I'm going to ask one question only, because I like what you say. It's interesting. Are you getting enough support from adult social care in this?
Yes.
Yes.
Absolutely. And this is a genuine, I have no qualms in saying that. So very much working with Jo Beatty, Linda, Justine Henderson, who many of you may have met. So we're looking at those pathways across health, education and social care with a real, we've got a new transition tracking system bringing partners together. We have a new 16 to 25 and a young adults panel supporting that transition from children's to adults, sort of mental health, but a real commitment to try and work on that earlier, so that we don't leave it till the very last minute and leave families in a position where they don't know which pathway they're on. Is it learning disability? Is it adult social care? Is it universal services? So no, definitely working in partnership, aren't we, Linda?
I was just going to say that we've now got a structure around that working in partnership. So Linda and I, over the last, I don't know, six months, have inaugurated monthly, if not meetings, and that allows us, just as this plan and strategy does, it allows us to be more coherent and transparent and also accountable. It is, as always, when you work in this way, you start to lift more stones, you start to realize more needs, so we've got our work cut out for us, but also we're beginning to see real progress as well. I'm conscious, Councillor Nadia wanted to speak. Sorry.
Thank you so much. It actually ties very nicely with what I wanted to ask about, which obviously, as Health Watch, we commend and acknowledge the plan to strengthen the young person's voice in their own transition planning and implement the new 16 to 25 young people's mental health service. But I'm sure we will all agree of how important it is to hear the resident's voice in tailoring individual service delivery. And through our young person mental health service, we know that post-COVID, young people's mental health in the borough has been negatively impacted. And we also know from outside research that this actually is true for the rest of the country. So what I'd like to ask is if the new 16 to 25 young people's mental health service is only for children with a disability, or for children who have special educational or additional needs, or for all children in the borough? And if so, what changes have been made to accommodate children with a disability or children who have a special educational or additional needs, additional or longer mental health sessions, for example? And also I'd like to ask if easy read surveys or alternative feedback mechanisms such as engagement drop-in sessions or discussions have been created for young people to feedback on the new strategy. Thank you.
So I'm looking at Helen in case you want to help out with the 16 to 25 young adults panel. So that was co-produced with children and young people and across North West London, so including service users who access West London Trust and CNW L, which is the other provider in North West London. It's for children and young people who are already within CAMS services, who are moving on or who are referred in at that sort of transition age. So there's flexibility to stay in children's services for slightly longer, or to move into adult services earlier. So we had some very powerful feedback from some parents previously whose children and young people happened to be turning 18 in the last year of A-levels and were potentially going on to university, and who'd had very well supported by CAMS and who were very concerned about needing to move on to an adult mental health service for the last year, and a very stressful year for those of us who've had children who've gone through the A-level pathway, and knowing that they would also then be moving on to another service if needed when they went to university. So that flexibility has been really helpful in terms of not being that rigid, sticking to ages. And some of that panel is about consultation to wider services, and some of it is about moving children and young forward. What's the most appropriate time to transition? And there is a new ASD lead in the trust who's working really well in terms of supporting that. How do we make sure some of our adults offer is very cited on the particular needs of young people with autism. So how do you make talking therapies, work and things? So yeah.
I noticed the time, so I don't know what the time is now, but I know it's time for you to go. I just want to add one little thing. I like very much, you're going to come back to things. I like very much the focus on how do we know when we've got there, really, the measurement. Can I just, when we come back to it, and you're going to be talking about the plans and how such are going to work, I'd be very keen on seeing a little bit more there about how you're actually going to be talking to the children, the young people and the families themselves about whether they're satisfied with the support they're getting. But just a comment rather than asking you to say anything, but I would like to talk more about that, because that's what you've been doing in co-production and so on. Brilliant. Well, thank you very much. I think it's been very interesting. I'm sorry it's been such a short conversation, mostly very long to you. I think we're all thinking about these conversations. You start going and you think the more it goes, the more you want to go on, because it's really extraordinary subject. But thank you. And
we appreciate your interest.
Come back. No, do come back with the more detailed plans, and we'll talk about some of those, and we'll allow a little bit more time for that. Thank you very much. Thanks for what you're doing.
Thank you. Good evening.
Thank you. Bye then. Good. So what we're going to talk about now, and I have to say, sorry, just before, I mean, they're off now, but I hate to make a political point, but when I talked about Every Disabled Child Matters, I did it at a time when you had a government which was prepared to spend money on disabled children. So when we lobbied very hard to get Ed Balls, when he became Secretary of State for Children, Schools and Families, to do things for disabled children, to understand the challenges they face. And he made £340 million available for short breaks. He made £14 million available for transition. And it actually, because you think these all things happen at national level and no one ever sees it, but we've talked to people at local level, parents, and they got this and it made a difference. And you come in, we lost the ring fencing. One of the first things the government did was end the ring fencing of this funding. And then they don't keep pace with need, the same as the NHS as a whole. And you have this ridiculous austerity, and they wonder why the country's in the state it's in. However, However, let's talk about the Better Care Fund, which again is our way of trying to scrape money together for the things that we need to do to keep people, among other things, out of hospital. So Linda, why don't you tell us about the Better Care Fund? You're going to present introduction. You're as strategic director of independent living. You're going to talk to it with Julius as well.
Yeah,
This is
Chair.
you just say what it is,
Yeah,
and then
will do.
what we were going to be asked to do.
Yeah, sure. Thank you. Unfortunately, it's not as sexy as the SEND strategy, so
It's been quite
I do
sexy recently.
apologise for that. But it is part. It takes over our life, Chair, and Sue can comment on that, and so can Julius, bless him. So the Better Care Fund is our only pooled budget locally that we have with the NHS. We have had the Better Care Fund now for about 15 years. The government keeps saying it's going to review it every year and it never does. But I'll leave that for politicians to comment on, not me. We have always managed this at a local level between, prior to me, Lisa and Sue and Janet Cree. I was involved as well as some of our commissioners. And we've always had a submission date around June. So this has always come to Health and Wellbeing Board. It offers a range, and any of the detail Julius can answer, but it's a range of pooling of money, which basically helps people, helps services to be set up to get people out of hospital as quickly as possible, to ensure people spend the least amount of time that is required to move out of hospital. Because despite some people's views, actually hospitals are not safe places for people who don't require them to stay into. So we've got a range of services that this report is talking about, funding, a lot of contracts in there, including our reablement service, our home care service. We've got mental health, homelessness services, because we're very much doing around prevention of people going into hospital as well, which is absolutely key to that. And a lot of our work day in, day out is spent on that. We were ready and in June this year to submit our plan. There's a lot of work goes underneath the scenes, and it has become an industry. And then at the 11th hour, I have to say, the ICB, so it's the Integrated Care Board across Northwest London, asked for further information from all 8 local authorities. That meant that actually the submission was put back to the 4th of August. And I have to say, and special thanks to Sue and her team, and to Julius and all his hard work with his commissioning team, we managed to get to a place of agreement and a place in where we would work together. So we've had a memorandum of understanding in place. That's been signed off, and we agreed that outside of this board with the chair, because it's a requirement for Health and Wellbeing Board to see it. So tonight we submit to you this funding for this year. As always, we bring back a year end and say what difference has it made. I'm really proud to be in Hammersmith and Fulham because we have a really good discharge rate. We've got consultant strike this week. We've got junior doctor strike this week. When I looked at the delays transfer of care, there was one person for Hammersmith and Fulham, and that person was actually, we already knew about, we were managing them. So I'm really pleased that we're not part of the problem, but a lot of that comes because we are commissioning the right things at the right time for people, and we have a very tight grip of discharge. And just a final thing to say, this has been to the Health and Care Partnership Board, and the board will also be reviewing the outcomes, including the discharge management and the numbers of discharge. That will be on a regular basis now. Thank you, Chair.
Good. Thank you very much. Does anyone have any points they'd like to raise or clarify? Just like I'll let other people come in. I'd just like to raise something, which we, for years now, we've been working locally in Hammersmith and Fulham, haven't we, with the NHS, local NHS, and Sue's done a great job again this year working with the council on this, and the local NHS, what we now call the Health and Care Partnership, which is the two coming together, worked as always on developing the better care plan. And then we put our submission into the NHS, and they might ask a couple of questions, but by and large, it gets signed off, and then comes to us here, and we start. Well, part of that process is our signing it off, and that's happened all across North West London and the country. And this year, the NHS came in, not the NHS locally, which has done a great job, but the integrated care system, which is developing, which is the 8 boroughs, which runs the 8 boroughs health systems across North West London. They came in at the last minute, and we had to stop it all. Is that right? Do you want to say a little bit more to explain what actually happened? Because it was a huge challenge to you and to the local NHS that sorting this out.
Yes, it was a massive challenge. We were ready to submit in June, and then we were requested by the Integrated Care System Board to provide further information on the outcomes. They wanted to look at some consistency across North West London, and there was a lot of debate. Quite heated debate, I have to say, at the board level, the NHS North West London board level, which was difficult to manage, because whilst you want to get consistency in terms of clinical outcomes and social care outcomes for people, we have to build a better care fund around our local communities and the needs of those communities. So there was some real debate about how can you do that. This is not something that can be controlled at a North West London level. It needs to be led at a local level. That was a really difficult time, I would say, if I'm honest, and Sue may want to add shortly, but there was clearly, and this is my interpretation, a lack of understanding of what social care does and what the localities do and working together. There was a sense that actually we could probably get some efficiencies out of the Better Care Fund, and there's some duplication of funding. And at the 11th hour, as you rightly say, Chair, we were asked to respond to several questions about the outcomes, both financial questions and outcomes, which we agreed to do. We agreed when we met, there was a couple of directors of adult social care met with the strategic director of finance, and the driver was coming from the finance team.
That's for the ICS integrated care
That's
system as a
the
whole.
North West London ICS level, yes, not locally. We agreed that we would answer the questions and that we would, in fact, do a review of the Better Care Fund for next year. So that's 24-25. We couldn't change anything for this year because, as I said earlier, a lot of this is based around payment of contracts, which we're already well within. And we have contractual compliance we have to maintain. There was a lot of toing and froing between that. And I have to be honest and say that, you know, I was one of the directors of adult social care who refused to respond to all the questions because I felt it was unnecessary. And I felt that there was some underhanded way of trying to get money out of the system. I'll just say it that way. That got to a point where we were left at one point where Sue very pragmatically put her feet in my in tray and said, right, we're sorting this out. And we did. There was some heated debates and there was a lot of growling, but we did it. And we, you know, that's where good partnership gets tested, doesn't it? So we managed to agree the submission for this year, and we agreed a range of indicators that we would meet. We agreed the memorandum of understanding of how we would work this year and how we would work next year. That agreement includes, and it's really important, that as a North West London ICS and the 8 local authorities will agree the terms of reference for next year's review of the Better Care Fund. So it won't be done to us, it will be done with us. That was very clearly said in the memorandum of understanding. It was raised through our political cabinet members and leaders and deputy leaders. There was a lot of debate at a senior strategic level with the chief execs as well. And in fact, it culminated in a conversation at the informal integrated care board, which was actually face-to-face 2 weeks ago. At that board, partnership board, I beg your pardon, yeah, there's so many boards, it's unbelievable. At that partnership board, which was very helpful, Rob heard the chief exec actually gave an apology for the way things had happened, how it had happened. And there was an acknowledgement that because of the way it had happened, it had damaged a lot of trust and confidence between ourselves as local authorities and NHS partners at a North West London level. If anything, I would say at a local level, it strengthened our partnerships and our relationships, and Sue may wish to comment on that. As a result of that now, we've got Alex Dewsnap, who's the Chief Executive of Harrow Council, is the Chief Exec, North West London Chief Exec for Council Lead for Health. He's agreed to pull together a group of directors of adult social care, which is actually tomorrow night, to look at what we want to get out of the terms of reference. What are the must-dos? What are the non-negotiables from us? We will then come together as chief executives, directors of adult social care, and importantly, directors of public health as well, and talk about what we've learned from that experience during the summer. And more importantly, how are we going to change the way of our behaviours and work better together? So we've got in train, a ways of working agreement with the ICB, and we will come together. Really important, again, face-to-face, not on Teams. We will agree the terms of reference, and we need to agree the terms of reference before the end of October to start the review, because we start our financial planning in October as a council. So that's where we are. It's been a difficult summer. I very much welcomed the fact that we managed to get it just before I stepped on a plane. It was all sorted. But I think we're in a good place. There has been no reduction at all in the commitment to social care in this, and there remains a commitment, and we will continue, and I will be very, very vocal on behalf of social care that we'll maintain that service and that funding.
Thank you, Linda, and thank you for all the work you did in sorting this out. And Sue, thank you as well for sorting this out. It was I think it's worth just reflecting on what happened here. I mean, to put it in even simpler terms, the finance director of the integrated care system said stop the whole process, which has been agreed for years, because he decided we all had to have one single way of doing things, and he wasn't happy, apparently, allegedly, with how one single council was doing things, and we all got caught up in this. What it's thrown up, and that's perhaps too shorthand, but it's not. Out of a crisis has to come an opportunity, and what it's thrown up is what we've been saying since the beginning. This is a brand new world we're in with the integrated care systems. You know, everyone thinks it's about integrating between councils and the NHS, and it is, and this is an example of that. It's also about integrating between the bits of the NHS which don't work well together. Doctors, mental health service trusts have to work with hospitals. It all has to work well, and it doesn't. So the whole government's insistence on an integrated care system is a huge, huge challenge to us all, because we're not used to all working together in this. The 8 boroughs across North West London are not used to working together. The DASs talk, the directors of adult social care, they talk, but they don't really work closely together, nor do the chief executives in the same way. All the public health directors, and we're very lucky in our DAS and our public health director. So what's happened, and the NHS, we don't understand the NHS perfectly, but they really don't understand councils, and getting them to the acceptance that they have to work with people, but they don't really understand us, and they need to understand us better, and they need to want to understand us better. Getting to that point is actually a good thing, because the more that they understand us and the more we understand them, the more we can work together in a clever way. So out of this, and the NHS, of course, is very top down. Someone who's a finance director in an integrated care system is used to being able to say, jump, and everyone else down the road says how high, and that's it. Whereas with councils, which are all locally based, you don't do that. So he's probably learned a few things from that, which will be helpful for all of us. The fact that you're now getting together as a group of DASs wouldn't have happened in the same way if this hadn't happened. So it's made us all coalesce much more and work better together, which I've been arguing for, as you know, for a long time. In the sense, shared fury has led to a shared desire to make things work better. So the fact that you're doing, the next thing I'll be looking for, and we'll all be looking for, I guess, is the terms of reference of the review that you come up with. How well is that going to be accepted as the terms of reference? And then assuming that those are accepted, it becomes the terms of reference, the next thing we'll be looking at is the review itself. How properly is it conducted? How much detail does it go into? How much does it reflect our views in a fair and proper way? And the outcomes of it. So there's plenty, this sounds very esoteric and sort of how many angels on the head of a pin. But when you have an integrated care system which covers it, I never remember exactly the numbers, it's 2.3 or 2.6 or 2.8 million people who can, but it's the biggest in London that they're doing. We have to, there will be issues will throw up, will get thrown up. They will cause tensions and difficulties as this did. And politically, there was a lot of very concerned conversations that took head at political level. But if then all the parties come together as they have, apologies given, determination to work better together, we have to hope that this will lead to a better way forward. So next year, when we come to talk about the Better Care Fund, we can just say, yes, you remember what we talked about last year? It's all fine this year. And that's, I think, all our ambition. Sue, I see you want to add something.
Yeah, I don't want to repeat what Linda's already said, because I think we've been through that, but done that, got the t-shirt, and it was quite tricky at times. But I think, as Linda said, it rightly tested some of the partnership relationships, and I think, you know, we resolved the issues because we worked together to do that. I think fundamentally what the ICB was trying to do was have that spirit of consistency so that, you know, things do look the same. But as Linda quite rightly referenced, Better Care Funds are local, they're designed at a local level to meet the needs of what we need to do. And I think the timing was completely sort of out of kilter with what we were trying to achieve, because we all had deadlines. So it did throw us. But I take on board what Linda has said, and the fact that actually we have got that meeting tomorrow about the terms of reference of the review. And obviously health and social care are going to be both involved in that. And I think it is really good to have all 8 councils at the table to work that through. I think there will be some lessons learned. I'm sure you've already heard those from Rob as part of the ICB, but I think, you know, as a health and care partnership, we did roll our sleeves up and we did get it done. And I think that was the reliance on local relationships then to sort of make that happen. So yeah, big thank you to my team, Caruth, who's now left and gone off to work in a different system. I think it might have tipped him over the edge. But certainly Carol, Julius and Linda in the team, I think it was certainly from the finance perspective, it was yeah, tricky, but we got there in the end. So yeah, and hopefully it's all signed off, and we should be getting our assurance through from national as well.
Thanks very much, Sue. Linda, you want to add something?
Yeah, just one final point, really, just for transparency. I do think there were some lessons learned on behalf of the local authorities as well, that we need to be really open and honest about. So yeah, I'll be putting some of those into the system as well.
I think the way that we work together, it definitely, the needs there need to be acknowledged. And I've been trying since the beginning of the ICS to discuss those with colleagues of mine, and I think they understand. Some of them are closer to these issues than I am. And it's, yeah, I'm still saying an integrated care system is a good idea. If you try and constantly make everybody exactly the same, and you say we all have to have equal inputs and equal outcomes, and you ignore what's going on locally, however, it won't work. So there has to be the flexibility. And the ICS may actually never work, but we're going to give it a go. We're going to try it. And if it doesn't work the way it's intended, at least we as local authorities will work better together, and our local NHSs will work better with. So we'll keep bashing away, but I'm determined to make it, I'm determined to take them seriously. what they say about an integrated care system and about working with councils as equal partners, when this sort of thing happens, it is not what the legislation was planned for, and is not what's meant to be happening. So I'm holding them to account very much on the basis of what the ICSs are meant to be about. And I think that the more that all parties understand that, the more likelihood there will be of a successful ICS.
I think just to finish, I think the ICS, I think the big learning point for them is the ICS isn't just about the NHS. It's about the NHS and local authorities, and including not just, I would say, not just social care or children. It's the whole of what local government can bring to that partnership, including housing and health inequalities, etc.
Exactly. And once they get that and they start really understanding it, then they're going to come back to us with all sorts of challenges, which will make us think again about things. But that would be a much better place to be in than where we are now. And indeed, in housing, huge issue with the quality of much of the housing stock that we have to deal with. And the NHS, it's constantly doctors constantly writing letters. Can you get people a better flat? Part of the problem is the resource that we have to address this with, and maybe the NHS can support us in that area. And that's also something where I think ICSs need eventually to go. Good. Helen.
Thank you so much. Thank you, Linda. And having worked in, obviously I have a council role, but having worked in health, I couldn't be more behind an integrated approach and funding for this. But Linda, I had a point that I feel sort of compelled to make, and I think that we could transform and do it brilliant here. But before I went into it, I wanted to just double check the DTOC stat that you said right at the beginning. You said, just wanted to double check it because it didn't quite align with delayed transfer of care, or otherwise actually the NHS England uses it, but doctors will usually look at medically fit discharge. That would be the term that they use.
So I think it's a really valid point. I think part of the issue is the NHS England keep changing the measure. So it goes from delayed transfer of care for medically fit for discharged, or medically optimised and therefore don't need to reside as well, is the other phrase. So part of the problem we have, and part of the challenge, which is why we're looking at it quite forensically locally in the Health and Care Partnership, is the different data that is collected around and the acute submit data, which doesn't tally with social care data. It doesn't tally with primary care data either. So we have actually come together to try and bring our intelligence together to get one version of the truth. We're just rolling out some IT throughout our acute, which will bring together both social care data and NHS data, which will give us a more accurate picture. What I can say is not from any database, from a manual trawl of people across Northwest London that was done on Monday of this week, there was one person that was medically fit for discharge waiting for social care intervention that was waiting in a residential home. All the others had planned discharges. There were P0 discharges, which are those who don't need support. They go directly from the ward and don't come to us. Home care support packages and people who step down into rehabilitation beds, which is across Northwest London, that's with the NHS, and then into residential and nursing care, which is P3. And for Hammersmith and Fulham, there was only one delay. There was 56 overall.
So I'm so sorry, I'm going to come back on this because I'm afraid, Linda, that half a mile down the road in Charing Cross, I have a doctor who's let me know. I did a ward round last Thursday on a 24 patient ward. 15 of those patients were medically fit for discharge. Some that have been the case for months, for only a handful of them discharged by the end of the day. One guy waiting 2 weeks for a key safe to be installed. And one of the key problems is the discharge coordination team who aren't particularly proactive, and acknowledge that Charing Cross serves a large local area, not just Hammersmith and Fulham. Yeah. But I think that my practical point is, I think with better care funding, I wonder whether we can work really pinpoint to get a much more proactive team who can broker that if the data is has a discrepancy in it. I wonder if we can make a case for a funded position.
And that's what we've done with with the Better Care Fund with the BI data. I think Sue wants to come in as well, if I may, if that's all right, sir, Chair.
Yeah, hi, I just wanted to come in on that point. So we're also being we have system-wide calls across the 8 boroughs with all of the acutes and the community providers. So we are going to be looking at this data sort of with a level of granularity as we go forward. So and obviously it is a moment in time, the data changes each day. So I've got one of my team that is currently on the discharge calls with Imperial on a daily basis. And I suspect, given the system pressures that we're under this week and probably over the next coming weeks, that may well have to continue, given that we're sort of heading into winter. But I take your point around the detox. It is something that we are looking at, and there are, you know, quite significant numbers of patients that are in hospital that don't necessarily need to be there. But I think from a Hammersmith and Fulham perspective, we need to work as a partnership. And we said that we would look at these as part of our executive group on a regular basis as well, to sort of do that check and balance to make sure that we are doing everything that we can to get people out of hospital.
I will just finish by saying I know that we were absolutely leading the way nationally during COVID, so I know we have a team and spirit to do it. I am slightly concerned about the discrepancy in those two numbers, and think, given it's half a mile down the road, if we could make the case for some funding of someone who is the right person to broker this, it would be unbelievably impactful.
What I suggest is, I appreciate you raising this point, and we'd be good to pursue this outside the meeting. And it's always helpful to get the doctor's perspective. I mean, we all have about the NHS. Everyone has a perspective on someone else. It's always someone else who's not doing the right job, and people don't always see the full picture. But I do think it would be helpful, Helen. Why don't we try and arrange a meeting outside of this, perhaps to CMB, Cabinet Member Board, where we can discuss this in a little bit more detail, because it's an interesting point that's raised. I see Natalia and I see Sue.
Thank you very much. I just wanted to thank you. And I mean, from what you told us, it must have been a very sort of intense time. And that you have asked more information. And then also asked more information for beginning of August. I think that's the day that you gave right in the middle of summer as well, since to go on leave. I think integration, collaboration, partnership. So it's just very frustrating to hear that process. You mentioned that you feel that there's a lack of understanding of what social care does. So what do they need to do to better understand what's done at local level, and also to see us as equal partners, local authority equal partners also, and the impact that those decisions have that can affect the residents. So badly. Thank you.
Thank you for that. So at the Informal Care Partnership Board, we did have a discussion about exactly that there is a lack of understanding of social care, and each local authority delivers social care in a very different way. Of course, we have our free home care, which is great. We have other incentives around dementia as well that is working really well. So what we agreed to do is go away with the Director of Adult Social Care and come up with a presentation for the Partnership Board for when we get together about how we work together to help them understand the role of the local authority. Because one of the things that we have very clearly been saying for a number of years now is, whilst we've got national drivers around discharge and KPIs, hospital discharge is about a fifth of what we do as directors of adult social care. We focus a lot of our energies on prevention to stop people going into hospital, and we do that very successfully as well. So I think they need to understand the different models, the different funding streams. I think it is just a perception, and I have worked in the NHS and I've worked in acute and in CCGs as well before they went into ICSs. And it is a very different world, and it is really difficult when you're in an acute hospital to remember and understand what's outside of the hospital, because the pressure by NHS England is very much on the acute hospitals. We've had that conversation with Tim Orchard at Charing Cross. There is an awful lot of pressure on the NHS to achieve widgets, count numbers now, which is great in one respect, but it doesn't improve the quality of the care, neither from a social care perspective or from a health perspective. So it's really important that we start that journey to understand how we both work together.
Thank you very much. I'm going to take a last question from Sue.
Yeah, I was just curious, really, when you're talking about patients being discharged from hospital, does that include patients that are in A&E? Because earlier this year, I spent 5 days in an A&E ward, but I wasn't officially admitted to hospital because I was in A&E. And it was full of a ward of mostly older people who were just flat out refusing to go home because they didn't feel confident in going home. I couldn't wait to go home, but actually it was hugely, it wasn't this borough, I have to say, but it was hugely held up because they couldn't get either adult social care or transport sorted out. But I just wondered if our statistics include discharge from A&E.
So at the moment, and I know Sue wants to come in, they don't include discharges from A&E, but we do have staff placed in A&E to do exactly that they in-reach into A&E, because we've a duty to make sure that if somebody doesn't need to get into hospital, we can get them out as quickly and as safely as possible. I think Sue wants to add to that.
Yeah, it was only just to add that obviously you have to have sort of an admission, you have to be formally admitted, and then that would start to be sort of part of the numbers. So you'd have to be admitted sort of from A&E to a ward. So if you were on somewhere like an acute medical unit, you would still be classed as an admission and you would be discharged from there. So it depends on, you know, where you were, Sue, in the system. If you were just in A&E, sort of, you know, in a waiting area, then you would still potentially be admitted, but you wouldn't necessarily be counted in the numbers under that.
Yeah, I was in an A&E ward, which I didn't ever quite get to the bottom of understanding exactly what that was. I was just told I hadn't been admitted.
Interesting.
It does sound slightly Alice in Wonderland. Linda, did you want to come back?
Yeah, I think a lot to manage the pressure in A&E, there's been a lot of areas which are more of observation areas. So there isn't a decision to admit you yet, but we're going to observe you and see if you need to be admitted first. Yeah, just to reassure Councillor Rowbottom, really, I think at any one point, you know, I'm bragging about my one placement needed. Tomorrow morning, I could report 10 delayed discharges. I can never tell how many people are going to come through the door that Hammersmith and Fulham. And, you know, this is where it's really important that we keep track of where patients from Hammersmith and Fulham are being treated as well. Because, you know, at the moment we get Imperial is our main area. But where we see some of our NHS plan changes about moving, I don't know, orthopedics to one area and not another, it means that our resources are spread thinner to try and get to these, what I call out of borough hospitals. But I feel confident, and I look forward to the conversation afterwards. I feel confident that we have got a good grip. Are we perfect? No.
So this is a bit surreal though. How can somebody be in hospital for 5 days in an A&E and they don't count as being in hospital?
And to make it even worse, I was there for 5 days before they realised on the day they discharged me, I had a broken leg.
Well,
they hadn't spotted it.
That's extraordinary. But how can so? Yeah, let's talk about that. Let's not lose that question though, because I mean, you know, we need to be measuring that because these people need support with if you've got people not in this borough, thank you for saying that, but they're people who don't want to go home because they don't feel safe to go home. If they're from hospital, then whether it's A&E or other thing, it does seem angels on the head of a pin that we're talking about. Anyway, the more we ask questions, the more answers we get, the more we learn, and the more we feel we ought to ask other questions. Sadly, we have to bring the meeting to a close though. I'm just going to ask you to do two things formally. One is to formally to note we had the discussion on the SEND Joint Strategic Needs Assessment. Can you formally note this Joint Strategic Needs Assessment, the SEND, and also the local area SEND strategy? If you've got a question on that, you're noting it, you're agreeing. I'm going to come back to that. I'm going to come to the work program next before we close. And the other thing is, I just want to do these two formal things, and then we'll talk about the work program. And then the other thing is, on the following the discussion we've just had, you're happy for me to agree the planned total expenditure and proposed schemes on the Better Care Fund 2023-25, and you're going to get a year-end report outlining the outcomes, just to note, and the difference that that's made for residents. So that leads us just to talk about the work program. I'm going to ask you for any suggestions for a future work program, and then we'll just use, please can note the dates of future meetings. Work program, Nadia.
Thank you. Not a suggestion, actually, just to bring something to the attention of the board. Health Watch's cost of living survey is live. We sadly, all the responses so far that we have received have been through face-to-face engagements. And I know that Carleen Duffy will be sending David the link to the online survey. And I was just going to extend a request if David could, or members of the board could sort of circulate to all your contacts and networks, so that hopefully we'll be able to reach more people.
Okay.
And
so we could do a piece. Have you spoken to the comms team at the council about this?
I believe Carleen has, but she did, obviously she did want me to mention here as well.
Right.
And
the main thing is you get the council to stick it out on the e-news and on Nextdoor.
Very good suggestion. I'll pass that on. Okay. And another thing, we'll obviously be sharing the preliminary findings with service leads in early October, so that any issues arise can be mitigated before. I think it's the end of October. I'm not certain of the date, but let's just say the end of October.
It's a cost of living. It's a survey of the impact of the cost of living crisis on health, or on everything.
On everything, but health primarily as well, because there are.
It'd be good to bring it to there. We have a cost of living group in the council, which is chaired by Rebecca Harvey, Councillor Harvey, and myself. And it would be good to come and talk about it in that meeting as well. We have a lot of charities there. We have the food bank.
When is the meeting? May I ask?
Linda, could you possibly be kind enough to find out and let them know and make sure that they're there? Because you're very closely and helpfully involved in this work as well. Would you also, Linda, would you mind terribly talking to comms and asking if they can publicise this through the e-news and through Nextdoor? I do think it's important that we really capture.
Thank you very much.
I know we know anecdotally people are going through a bloody horrible time.
Because it also gives us an opportunity to sort of mitigate anything before kind of peak,
winter responding as possible.
Pressures.
Good. Thank you. Work program.
I wondered if we could possibly add like a breakdown of the ICS transformation plan and who has budgetary responsibility for it, aligning with our strategic documents.
Let's unpack that, because it sounds really interesting. You want the transformation plan, and who has budgetary responsibility for what?
For that, so that would be the ICB, and whether it actually correlates with both data and our strategies internally in the council, how we define health needs here and well-being.
So that Linda, you might be able to help here, because I think we should unpack that a little bit, so we're absolutely clear we're asking for the right thing and getting the right information. The ICB has its plan for the spending plan for the year. It's also developing a strategy, but that's a slightly different thing. So when you say transformation plan, are you talking about what it's going to do next year? What it's going to spend money on next year?
So not to get bogged down in jargon, it might be called something different, but basically it would be really good to have representatives from the ICS and ICB to check that what we think is the priority here is also their priority for the same set of people, if that makes sense, just to basically do a tectonic plate alignment between the two of us.
Yeah, I think the ICS, the ICB, the board and the system have actually presented the strategy here previously, the draft strategy, and they're engaging in public directors of public health, directors of children's services and adult services. And there's also a conversation about the health accountability board, which is the board that's been set up with all leaders and cabinet members with the NHS as well. So we have tasked them to come back
with the NHS. It's just the council's getting together.
Sorry,
to talk about
apologies.
stuff. No, that's all right.
There's that many boards. I get mixed
the
up.
health
Which one
accountability
I'm
board is
talking
just councils that aren't used to talking to each other about this stuff. So we set up this board and we meet every so often. Sometimes, yeah.
So we will be expecting them to come back with strategies, where I'm getting to, and they've very much got the high level strategy, but similar to the SEND strategy, they need to work on the how and how they're going to do it. So I think that piece of work should be around probably in time for the next Health and Wellbeing Board?
Yeah, it's an interesting question. The question we need to ask is it's very worth exploring, because the strategy has been here, and it's been to the Policy and Accountability Committee as well, and people from the ICS came and asked questions, and that's happened in 8 boroughs, and it has actually made a bit of a difference to the strategy. It's a bit clearer. It focuses on some things. The next thing is a bit like the strategy that we talked about for children with disabilities and SEND, is going to be the implementation plan and the measurement. And I think that I'm thinking how we could, because it's going to have to be implemented in each borough, their priorities are there, Linda and Sue, are there priorities in the strategy which aren't necessarily reflected in our local priorities, or vice versa, local priorities which aren't reflected in the strategy? Can I bring Sue in and then you, Linda, because she's, yeah, Sue.
So I think, so from a health and care partnership perspective, we've got sort of priority areas that we're working on this year, and they shouldn't be misaligned with the strategic document. One of the questions that I was going to ask Councillor Rowbottom was about, is it about sort of programme budgeting in terms of what we're spending our money on in health and what you're spending your money on in the council, and trying to align that? Is that what you mean by a transformation plan? I'm not fully...
I don't want to, yeah, sure. I might have used the wrong jargon. Essentially what I'm getting at is we don't have a lot of NHS people, and we don't have as many NHS people in the room today as one would hope. And I am not the most, this isn't my brief, but it strikes me in several meetings, not least in my own with children education, that there is a discrepancy between the need we identify and what health are investing in, how they're articulating it. Even the sort of slightly strange reaction to the word diagnosis that I had earlier, it makes me a little bit worried that we're not all on the same page about pinpointing some of the most complex issues. So it would be good to, obviously happy to flesh out, we can't go with anything that broad, but I don't necessarily think this is the right forum, but it would be good to just check that data is aligning between the two and priorities and spend accordingly. And very nice cat.
Mad cat, I'm really apologising.
No, your cat is a definite addition to the meeting. And I think, this is you have the healthcare partnership, which is the local Hammersmith and Fulham NHS and council working together. So you have to hope that the NHS and the council agree on what they should be doing together locally. And then you have this so that's much more of a partnership, and it's because it really got going in COVID, and it's worked well since then. And then you've got the NHS at the ICS level, where we had to fight to get 3 councils on the board, and they're still, as we've discussed, they don't really get councils properly yet at that level. So that's still very, very health focused, and the councils are having to, well, the councils haven't put forward in a concrete way what they think the ICS should be doing at the 8 borough level, the way they have at one borough, the single borough level. We've done a much better job of that. So we've got this strategy coming up, which we'll see what we think of it. I don't know whether we need to do an exercise where we take the ICS strategy and we set it against the local priorities we've developed, and we look at the match. And I think probably that would be a useful exercise. And we can spot, whether we talk in the data, obviously the data is informing our local strategy. We're not going to be probably examining the data for all 8 boroughs. Unless we are extremely free, we've got a lot of time. but so we could, but I think it might be a useful exercise to, I can see Linda nodding helpfully, to look at what our priorities are locally. And when the strategy comes out, see how they match there, and see where the gap is, and what we might be able to do.
Can I just come back in as well? So, so I think obviously Nikki was working on a JSNA, wasn't she, for the borough? And obviously we've had the JSNA earlier for SEND, which is quite specific and sort of, for a small part of the population. But I think the other bit is, if we had that JSNA and our health and wellbeing strategy aligned to that, we could then do that piece of work to sort of, make sure that it dovetails in. I don't think there's anything that's out of kilter with what we're trying to do locally at Hammersmith and Fulham level, Northwest London level, and then obviously you've got your national priorities as well. So I don't think there's anything that's out of kilter, but it might be worth just having that discussion and having it as an agenda item to come and talk about it here.
Good, thank you. Linda.
Yeah, totally agree with what Sue says. And if people can remember, it is a few months ago now, when the strategy came here, there was a discussion about exactly how the investment or the money is going to follow the priorities. Now, we looked at the money separate at an informal partnership board to the Health and Wellbeing Board. And what we identified then, and I think it was yourself, Councillor Coleman, that identified it, the money that they put towards mental health, which was an increase, which we're really pleased to see because it's been a Cinderella service and underfunded. You can pay me after Helen. Didn't have anything in there about autism at all. So there was no identified autism. So I think when we did the strategy, in fairness to the ICS, they did ask us for our local priorities as a health and care partnership, and we did submit those. We have tested that and said, can we see that in the strategy? And yes, we can see the links, tenuous links perhaps, but we can see them. I think the challenge is not only can we see what our local priorities are in the strategy, but is that aligned in the finance strategy?
Yes, that's essential. That's absolutely, thank you for bringing us to that. That's absolutely the crucial thing. So it doesn't matter if we have priorities which aren't necessarily in the strategy, what's that going to mean for our funding? And if they have priorities which aren't our priorities, what does that mean for the funding? So I think that's got to be part of the question. It's a really, really good getting to the number of things question. And let's try and we take quite a lot of serious discussion. I mean, we're not usually set up for this sort of analysis, but actually it's really grown up adult to adult stuff to do. And it's something that we will bring to either the next or the one after that, depending on the timing of the strategy, not CMB, the Health and Wellbeing Board. And it's going to mean we'll look at how the strategies align, but what about the funding? Yeah, good. And I'm going to ask Natalia to make the final point.
Just quick comment as well. I'm thinking about what we discussed before in terms of the trust as well, and deciding which are our ways of working, agreeing the ways of working. Okay, there may be a strategy, there may be a strategy at local level as well, but I think there's an element of trust as well, and partnership and collaboration and integration that we also need to look at to make sure that we are on the same page.
In putting it in even plainer, if they're going to try and impose a load of stuff which they've worked out and they're going to tell us that this is what we want, but this is what they're going to do, that's the ICS is going to make a joke of what the ICS is meant to be. So it's all about the trust. It's all about them showing that they've listened to us and that we're not talking about them and us in the future, but we're working together in a new way. And this is all brand new. It's all being tested. There will be challenges along the way. The question is how, when we recognize the challenges, they are dealt with. And for me, the jury is still out, but I'm still being officially and perhaps even personally a little bit hopeful. Good. Goodness me. Who'd have thought that the Better Care Fund would lead to such stimulating conversation? This is the first year it has. A little crisis does a wonder.
I have to say I've loved tonight because it normally gets through and everybody goes, Better Care Fund. Yeah, okay.
Yeah.
So thank you for the question.
So, you know, well done the ICS for their big old hobnail boots and us having such a good discussion about it. So thank you very much. The future meetings, 13th of December and the 12th of March. Linda, very important question. On the 13th of December, will there be mince pies or not?
Yes, but there will also have to be fruit because it's health and wellbeing. Sorry.
What?
Fruit and mince pies.
Fruit and mince pies. Yes. Well,
no mulled wine.
No mulled wine, but you know what do you have? The fruit is the tangerines. Tangerines and mince pies and no mulled wine.
Yeah, I'll use your Costco for that. Thank you, Councillor Coleman.
No, use David. David will help you with that. Good. Helen, thank you very much for coming. You've been very silent as the grave there. Was there anything you wanted to add before the meeting finishes?
No, thank you. It's been very useful to hear about Zend and the Better Care Fund.
And your stimulating conversation about aligning finances and need. It's tricky, isn't it?
It's the big thing. It's the big nirvana which we're all striving towards. Okay, great. Well, Sue.
Sorry, very quickly, are we going to discuss winter pressures at the next meeting and what we're kind of expecting and anticipating?
I think it might go, yes, I think it's a good idea. We are going to be discussing them at the cost of living steering group. And I think it might be good to bring a report. Actually, it's a good question, because I keep thinking there are different bits of the council and they don't always, it needs to be, we need to share this. I think it'd probably be useful if we could have a discussion on winter pressures at the next meeting. Two things. First of all, how the NHS is just going to deal with the usual pressures of winter, but also how we're working together to try and deal with the extra health and well-being challenges facing people as a result of their cost of living challenges. Could we try and make that an item? I just think, or is that, am I asking?
It might be a bit too late for health by then, because we're in winter now. The pressures on the system are quite wintry at the moment.
Yes, I don't think we're going to be very helpful in necessarily saying, why don't you do this and that, but actually just talking about how you're
we can give the situation. We can do a sort of a situational update as to how it's been, but it's definitely winter this week. It feels like winter across the system this week.
It feels like winter. Yes, we're now in a permanent winter. I can only think that what might change it, the magic wand of a general election, who knows? But Linda, you're looking a bit reflective, not on that last point, on the previous one.
No, just to say there are obviously 2 points which you made. One, I think Sue was referring to, was how we're going to manage the winter pressures on the hospital and primary care, etc., which, as Sue said, we're in it now. We've got a doctor's strike and a consultant strike this week, so it's been really difficult. And then the second is the impact of the cost of living for people, for residents throughout winter.
Healthwatch's survey results by then, which would be really helpful.
Let's put Healthwatch's survey on the table for the next meeting to discuss at the next meeting. And I think a situation report, as Sue has suggested, on how the NHS is dealing with winter pressures, it's incumbent upon us to discuss that. And Sue.
Yeah, I think in fairness, it's not just NHS, it's health and social care.
Health and social care, yes. So let's bring that together to the next thing. So that would be the essence of the next meeting. It's going to be talking about how we're dealing as council and NHS together, and also take the Healthwatch report. So we're very much talking about the winter, the challenges. Does that seem okay? Good. Thank you all very much indeed. With that, we'll conclude the meeting.